Last time we have seen the lung volumes and capacities. We have dealt them in detail. So now today what we'll see is that dead space volume, FVC, FEV1, and flow volume loop. Okay, these four concepts are very essential to understand the spirometric analysis. That whenever there is disease in the lung, okay, just a minute. Mm, So, uh, Spirometry is done many times for diagnosis of the lung diseases, and especially the restrictive or obstructive lung diseases are the broad classification of lung diseases. At that time, we'll come to this every now and then. So, few basic concepts we should remember that there is a dead space, there is FVC, there is FEV1, and there is a flow volume loop. Now, these are the diagnostic tools in the respiratory physiology. Okay, so to start with, what we'll learn today is simple, the dead space. And the pulmonary function tests are the tests which are advised whenever you get a patient of respiratory disorders. Common respiratory disorders are asthma and COPD, which you will learn or which you will like listen every now and then. There are some uncommon that we'll come to know as we go further in the classes. So there are dynamic lung volumes. Earlier, when we have seen the other lung volumes and capacities, those were static. There was no time dimension to it. Now, when we say dynamic, that means there is a time dimension to it, that they are measured across time. Okay, that is the meaning of dynamic lung function test. And what are they? The force vital capacity. Then there is the force expiratory volume at first second. Okay, now remember this. This is one of the very important concept to understand, because the diagnosis and the differentiation of obstructive and the restrictive lung disorders does depend on this very simple concept of force expiratory volume at the end of first second. Okay, that is with respect to time, 1 second. Okay, then there is a flow volume loop. This is a typical diagram which we get as a result of spirometry, and this is printed by most of the spirometers. So when you look at the diagram, it is evident that what the disease is just by the look, and that will come at the end, and then we'll see what it is, and at the end we'll see again the MVV, that is maximum ventilatory volume. So to start with, now this concept of dead space volume I have introduced earlier when I was taking the introduction of anatomy of the lung. Okay, so during that time, what we have seen that the respiratory tree is designed in such a way that it is having some conductive zones and some respiratory zones. So by definition, what the dead space air is or dead space volume is. So dead space air is basically the air in the respiratory system. Okay, what it does, that is not exchanging gases. Now we know that air is composed of many gases. Okay, these are not synonymous to each other. Air is a mixture of gases. Okay, and what are the gases in the air? Major what we are interested today are the nitrogen, oxygen, and carbon dioxide. These three gases we are interested today, and out of that also the carbon dioxide and oxygen will talk more in the respiratory system, because that is what is exchanged and that is what we are looking for. Okay, then there is no exchange in this dead space. With whom? With capillary blood. Okay, so this is in general the definition of dead space volume. So volume of the air which is there inside the lung. Okay, but there is no actual exchange taking place with the capillary blood, and if it is not reaching to the capillaries, then it is useless for the body. Okay, this it is remaining there, and that's why it is called a dead space. It is unused. Okay, it is useless. That's why it is called as dead space. Now to elaborate this concept further, we have to understand what is ventilation and what is perfusion. Okay, there are these two terms again that you will be every now and then will be talking about these two terms. What is ventilation and what is perfusion? In some diseases, ventilation is decreased. In some diseases, perfusion is decreased. Okay, so what is this? What is the difference between them? So remember, ventilation is entry of the air inside the lungs to the alveolus. Okay, so respiratory passage up to the alveolus, it is the ventilatory passage, starting from your nose or the oral cavity, then the oropharynx, trachea, the bronchi, the principal bronchus, then followed by the bronchial tree. Then at the end, it will come back to a single respiratory unit called as alveolus. And in the alveolus, there is a membrane of that is called as the respiratory exchange membrane. And in vicinity of every alveoli, there is a capillary which is carrying deoxygenated blood from right side of the lung, right side of the heart, and then it is getting oxygenated, which will be carried to the left side of the heart. Now, this ventilation, if it is clear, what is the ventilation? Ventilation is basically the air entry or the air which is coming from the atmosphere and entering to the alveolus. This complete process is called as ventilation. Any block in this will be called as ventilatory defect. Okay, or blockage in the ventilation. Now the second thing is what is perfusion. Now if you see here what is happening, the blood is coming from left side of the heart, it is deoxygenated, it is giving carbon dioxide to the alveolus and taking oxygen from the alveolus, and it is happening across a membrane called as respiratory membrane. This particular process is called as the respiratory exchange, and the blood supply which is coming to the uh, lung alveoli or the lung parenchyma, it is called as the perfusion. Now, earlier I have talked about that parenchyma does have its metabolic function. For that, a separate system or separate circulatory system is there. But pulmonary circulation, whenever we talk about, we'll talk mostly about the blood which is coming from the right side, which is deoxygenated, and it is getting oxygenated in the lungs, and it is going to the left side of the heart, and from there it will go into systemic circulation. So this concept, we have to remember that there is ventilation, there is perfusion. Any block in ventilation will create a respiratory deficit, and when any block in the perfusion also can create a respiratory deficit. Okay. So now, for the types of dead spaces, there are two types of dead spaces. One is anatomical dead space. Means what? By anatomy itself, like anatomical design of this respiratory tree is such that up to the 16th level of branching of the tracheal tree, there is no exchange possible because it is not designed to exchange the gases. So up to 16 like level of the bronchial tree, the gas, whatever comes there, it will be stagnant, it will be useless, it is always dead. That's why it is called as anatomical dead space. Because of this is because there is anatomical problem in that. Okay, or this is the design of the tracheal tree. Anatomically, it is designed like that. There is no exchange possible if the air is inside this place. It starts from trachea and it ends up to the 16th terminal bronchial, and that's why it is called as only the conducting zone. Okay, because what is its role? It only conduct the gases. Okay, if you see here, it is called as conducting zone, and this is the diagram which we have looked into in our first few classes. Now there is second dead space which is called as physiological dead space. Okay, physiological dead space, it is from 16th branch to the 23rd, that is alveolar sac at the end, and this complete zone is called as the respiratory zone. And if you see here, small amount of exchange is possible from zone 17 onward. Okay, now normally if a person is healthy, in that case this physiological dead space will be zero. Okay, but anatomical dead space, it should be always there, it will be always there, and if it increases, it might be due to some anatomical defects which are possible in the development of the respiratory tree. Okay, so these two concepts you have to remember, that dead space are of two types. One is anatomical, another is physiological. Anatomical is almost fixed. What is the normal value of it? Approximately 150 ml of air. Okay. And if you now deduct the total respiratory volume, that is the total lung capacity, it is approximately 5000 ml. Okay. If you take a deep respiration, then in that case, this should be minus from that. And if you take tidal volume only, then 500 minus 150. So actually, how much is there? It is reaching to the respiratory zones, or for the exchange, it is only 350 ml. Now, the second thing, as a concept, we should remember that if at all, let's say this is trachea, and the air is entering from this side, okay, on both the lungs. So the air enters, the first bout of air which is coming down, it will go down to what? To the alveolus. Okay. By the time it is reaching here, what is being filled? Here also the air is being filled. But whenever we are exhaling, when we start exhaling, this air doesn't come out first. Which air will come out first? The air which is in this trachea or this bronchus and this conducting zones. So this air will go out, followed by the air from these zones. Okay. So now remember one thing. What happens is whenever we are taking inspiration, at that time air is taken inside. The first bout of air which is going in, that will go to the alveolus, and when we are exhaling, the dead space air will be exhaled first, followed by the air from the respiratory zone. Okay, this is the concept which we should remember, because this is the concept which we will be using to measure the dead space, because we have to measure it. Okay, we should have some method to measure it, and this principle we are using in there, that the air which is entering at the end and which is not being exchanged with the carbon dioxide, that air will be exhaled first when we are exhaling out or during the time of expiration. Okay, once this concept is clear, then we'll go to the next thing. That is what is happening when the physiological dead space will be created. Again, coming back to the earlier diagram, what we had the ventilation, then we had perfusion. Okay, so what, that if the ventilation is decreased or ventilation is blocked, okay, then what happens? Ventilation becomes zero. Okay, in that case, there won't be any dead space created, but the alveoli will be completely closed, so air won't enter inside. So will the air, the dead space created? No, the dead space won't be created here, but total lung capacity will decrease. Okay, but the second concept now, if there is blockage or if there is some problem in the perfusion of the lungs, in that case what happens? The air does enter into alveolus, but due to the problem in the perfusion, that is the blood supply or blood flow from the pulmonary capillaries, if they are blocked, or if there is problem in the respiratory exchange membrane, some disease where the thickening of the membrane might occur. What the disease is, we'll talk later. Okay, just concept we'll understand now. So if these things happen, then what happens? The air will enter here, air will get accumulated here, but there won't be any exchange. This exchange won't take place, and this air which will be over and above the dead space air or anatomical dead space, not anatomical dead space air, will be called as the physiological dead space. Now here is the concept which is being elaborated in this diagram. Now this thing is fixed. This is anatomical dead space around 150 ml. Now perfused alveolus is there, then there won't be any problem. But if this is blocked, then the air won't come here, so it won't be creating dead space, but it will be creating the uh, compromise on the lung capacity. But if the perfusion is paralyzed, or not paralyzed, but if the perfusion is stopped due to some reason, in that case, the air, the alveoli will be ventilated, but the exchange won't take place, and that air will remain dead in there, and that's why it is called as dead space. But what is the reason? It is physiological dead space, functional dead space. It is due to functional parallax which is there in the alveoli, okay, or in the perfusion. So once you understand that concept, now you can differentiate what is anatomical dead space and what is physiological dead space. Okay, Many times this is a very routinely asked question in the university exams or in your PG exams also. Okay, so understand this concept. The other numbers, everything you can get from the books. So go back to the books and read it there again. Okay, so now how to measure the dead space? Now many times you will come across such graphs in books. Okay, so there is a technique to read the graphs. Always look at the x and the y axis, what is there. So if you take this diagram, what is there on the x axis? It is air expired, means air exhaled, and on the y axis there is percentage of nitrogen, and then we are plotting a graph. This is the method by which we will calculate the dead space volume. Okay, now what is the fundamental basis of it? Again, we have to go back to the basic physiology, that the air which is entering inside the tracheal tree, okay, the air which comes at the end will be exhaled to begin with, or to start the expiration. That air which is there in the dead space area, that will be exhaled out. This concept is used to measure the dead space again. So how it is done and how this graph or this diagram can be read or can be drawn? There is a simple method by which it can be measured. What is done? Subject suddenly takes a deep breath of oxygen. Okay. Then what happens? Fills the entire dead space with the pure oxygen. Okay. So what is that? You are taking the person in a closed circuit now. It is not open respiration. What we are giving to the person is we are giving the person pure oxygen to breathe. Okay. Now what will happen due to that? Whenever person breathes in, the oxygen which is entering to begin with, it will reach directly to the almost to the alveolus. At the end, the dead space area, anatomical area, approximately up to by the zone number 16, will be filled at the end. Okay. Now that is called as the anatomical dead space, and it will also be filled with oxygen. Then what will do? Some oxygen also mixes with the alveolar air but does not completely replace this air. Okay, the oxygen which is going into the alveolus, it will also replace the alveolar air, but it will not completely replace the it will be mixing with the alveolar air, but it won't replace the alveolar air. Okay, because we have understood earlier that there is something called as residual volume. Okay, there was residual volume which remains inside the lung after forceful expiration also. So that one will be mixing with this pure oxygen. Then what is done? The person expires or exhales through a rapidly recording nitrogen meter, and graph is plotted. Okay, so what is done? The person is exhaling through a rapidly recording nitrogen meter, and a graph is plotted. Now this is the graph which we will get. Okay, now this graph, how it will be done. So the first phase, what will happen up to 0? If you see here, okay, here there is oxygen, and then up to 0 there is inspiration of the pure oxygen. Then we are giving time for it to mix with the alveolar gases and to get filled. Okay, then what we'll do? We'll ask the person to exhale into a nitrogen meter. Then as the person exhales, what will happen first? The air which is there inside the dead space air, that will be exhaled first. Okay, followed by that, what will be exhaled? Now the mixture of gases. Okay, nitrogen is one of them, and that is what we are going to measure. So here, first portion of the expired air comes from the dead space region of the respiratory passageways, where air has been completely replaced by the oxygen. In the next phase, the mixed air, we had a mixed air in the alveolus. Okay, it will come out. So when alveolar air begins to reach to the nitrogen meter, the nitrogen concentration rapidly rises. Okay, because in normal air also there is around 70 to 71% of nitrogen is there, and that is a major gas which can be measured. Okay, so nitrogen concentration, now from where this nitrogen is coming? It is from the air which were trapped inside the alveolus at the end of expiration. Okay, so that is being mixed with the oxygen. Okay, and that nitrogen which is exhaled now, which was mixed with the oxygen, that is what we are going to measure. Okay, so initially this graph will begin from here. It will take a steep, okay, rise, and it will reach the percent of the nitrogen, approximately 60%. And then once all the nitrogen is exhaled, then it will reach to a plateau level. Okay, so recorded nitrogen concentration reaches a plateau level equal to its concentration in the alveolus. This is how the dead space air measurement is done. Now, this is not enough. What we have to do is, now we have to take a calculation of this. Okay, this graph, the areas are measured and they are calculated by a simple formula called as VD. VD stands for the dead space air and VE stands for the total volume of the expired air. So there were gray areas, there were pink areas. Okay, so here this is the gray area and this is the pink area and this is the total volume of air that is expired. Okay, so by this, what will happen? The gray area multiplied by VE divided by pink area plus gray area. This is the calculation which you can practice by taking some numbers at your own. Okay. Now this calculation is important because many times in the exam also we can give these numbers and ask you to calculate the dead space air. At that time, what you should remember is the formula, that is VD is equal to gray area multiplied by VE divided by pink area plus gray area. This calculation is done to measure the dead space volume, okay, or dead space air. Remember this. Now, second thing of the day. Now, pulmonary function tests are the routinely advised tests to diagnose the respiratory disorders. Major respiratory disorders which you will come across are asthma and COPD, and sometimes some obstructive lung disorders are there. Others are restrictive lung disorder. Now, by the definition, what is obstructive lung disorder and what is a restrictive lung disorder? Obstructive lung disorder, there is some obstruction. Okay, there is some obstruction to the ventilation. Remember that, to the ventilation, there is some obstruction in the bronchial tree. It can be at any level. It can be at trachea, it can be at bronchus, it can be principal bronchus, it can be small bronchus, or even at the neck of alveolus. Okay, so all these things do come in the obstructive lung disorders. What is restrictive lung disorders? Restrictive lung disorder, there is the problem in mechanics of ventilation. Earlier we have seen that there is mechanics of ventilation. In the mechanics of ventilation, what is the main mechanical apparatus? There is a diaphragm, there are muscles of inspiration, there is a rib cage, then it is having the spinal cord, and inside that the lungs are located. Any deformity of any of these parameters will cause the restriction of the movement of the lung, and those disorders are called as restrictive lung disorders, and all of them can be diagnosed because they're classified basically either it is obstructive or restrictive depending on a simple test called as the pulmonary function test, and the spirometer is the instrument which I have shown you earlier that is used to diagnose these disorders. Okay, so three major things you have to remember for diagnosis of all these disorders. There are a few more parameters which are like beyond the scope of first year, that's why I'm not taking it here. Okay, so forced vital capacity, then FEV1, that is forced expiratory volume at the first second, and the ratio between these two, that is FEV1 by FVC ratio. Okay, so these three things we'll talk. And now, if you see the diagram again, what is there in the, these are called as again dynamic lung function tests because they are plotted against time. Okay, in x-axis, here the x-axis is there, the time is there on the x-axis, and on y-axis, lung volume is measured in liters. Okay, so now this is forced. If you understand this, the name itself, what it does, it is forced vital capacity. It is not vital capacity. It is called as forced vital capacity here, and FEV1, that is forced expiratory volume at first second. Okay, at the end of first second. It is not randomly like any second will take. Start of the expiration to the end of first second, how much volume of the air is exhaled by forceful respiratory effort, that will be taken as the FEV1. Okay, and then the ratio. Now to begin with, what we'll do a normal tidal respiration. Okay, if you do a normal tidal respiration, there will be 500 ml air which is taken in and the 500 ml which is given out. Okay, and then person takes deep inspiration. Okay, this is what is happening. The air inside the lung is increased from the normal, it is increased up to the higher level. There is deep inspiration is taken, and then person exhales forcefully into the spirometer. Okay, now this is again a closed chamber. Remember that the air, whatever is there present in the lungs, it should reach to the sensors of the spirometer. For that, leakage should be avoided. The effort of the person should be maximal possible effort should be given, and 3 recordings should be done. It is not only 1 recording. At least you should take 3 recording, and then we should calculate these values. Okay, so 3 recordings and best of 3 can be taken because it takes time to learn. Though we are expert in that or will become expert in that, but the patient might be doing it for first time in their life. So you have to train them a little bit, and then we can get best possible results of pulmonary function test. Now from here, after taking deep inspiration, person exhales into the spirometer, and with forceful expiratory efforts, then whatever the amount of air that is exhaled from the person into the spirometer, it is measured by the flow sensors which are present in the spirometer. And at the end of first second, remember now here this is 1 second duration. Okay, start to end 1 second. Now this is also 1 second, and where we are starting expiration, we are starting here the expiration, and this is at the end of 1 second. Now this volume of the air is called as FEV1. Okay, the amount of air that is exhaled by forceful expiratory efforts in first second of expiration. Now this definition is important. Forceful and at the end of first second. Now how much of the air can be exhaled in the first second? It is approximately 90 to 95% of the air can be exhaled. Okay, and only remaining 10 to 15% will be exhaled in next 2 or 3 seconds with forceful expiratory efforts. Now this thing is done for almost 6 seconds minimum. That is the standard protocol by European Lung Society and or European Pulmonary Society. And they say that what is the validity of the lung function test? Only when the person exhales for 6 seconds minimum. Okay, that should be taken as the standard standard value or standard duration which can be accepted. Okay, so expiratory effort should be minimum for 6 seconds, and when you do it for another 6 seconds, the remaining 10 to 15% will be exhaled, and it will give a graph or a plateau like this. Okay, so what we got? We got a FEV1, we got a FVC. Now vital capacity definition we got earlier in the last lecture. And what is the vital capacity? Vital capacity is the sum of all the possible measurable volumes together. Okay, except the residual volume. What were these 3 volumes? One was the tidal volume, second was the inspiratory reserve volume, and the third was expiratory reserve volume. If you club them together, if you add them together, what will get the vital capacity? And this is done with the forceful effort. So here it is called as forced vital capacity. Okay, now if you compare them, which is more, forced vital capacity is more than the FEV1, but which is more important here to understand? FEV1 is really important because it gives you the amount of air which is exhaled into the first second, and that is maximum air which is exhaled. Now the ratio FEV1 by FVC ratio, normally it is taken as around 85 is to 80 is comfortable. It is normal healthy person. It can be more than, but it cannot be less than that. Okay, if it is less than that, then we are coming to the diagnosis of the respiratory disorders. Okay, for that, second concept we have to learn, that is what is the difference. Okay, now this is called as the flow volume graph basically. Okay, this is a graph, that's why it's called as flow volume graph, and there is one other concept called as flow volume loop. Okay, so this graph, now the on right hand side, what you are saying is the normal FEV1 and FVC in a normal person. But if person is having obstructive lung disorder, in that person, how the graph will look like? Now this is the graph which will be there in a person who is having obstructive lung disorder. Now if you compare these two, what you can get is, if you are comparing with the normal one, FVC is reduced, post respiratory capacity is increased, total lung capacity might be increased, but the FEV1 is tremendously decreased. And mainly what you have to see is the ratio between FEV1 and FVC. It is approximately 50%, which is way beyond or way less than the normal acceptable range. Okay. So what happens in obstructive lung disease? Mainly the FEV1 decreases and the FEV1 by FVC ratio decreases. If you see this graph, then by the graph itself, we can say this is obstructive lung disorder. And then we'll go into the next thing, that there are two major obstructive disorders which we need to differentiate. One is asthma and another is COPD. Okay, COPD is chronic obstructive pulmonary disease. Okay, COPD, chronic obstructive pulmonary disorder or disease. Okay, so that will come to end, how you can differentiate between them by looking at the lung volume loop. Okay, now restrictive. In the restrictive, what you will see is the graph itself is decreased, the total lung capacity is decreased. Okay, and the FEV1 decrease, FVC is decreased. But now if you see what happens here is the ratio between FVC and FEV1 is around 80%. If you see the ratio is normal, but the all possible values, they are decreased way beyond, way below normal. Okay, so FVC is decreased, all those are compromised. But if you take a ratio, then ratio might be normal. This difference between restrictive and obstructive lung disease. In FEV, the obstructive lung disease, if you see here for comparison, FEV1 is decreased, but FVC might be normal. Okay, here FVC is also decreased and FEV1 is also decreased. Both of them decrease, so the ratio will be normal. But here only FEV1 is decreased, but FVC might be increased also. So the ratio is decreased. Okay, so this is difference between the restrictive and obstructive lung disorders. Okay, now the flow volume. Now this is the second graphical representation which you'll get when you do spirometry and when you look at the report of a spirometry. What is this loop? This is a very standard loop, and this is a diagnostic tool. Just by looking at it, you can understand this is normal, or this is obstructive, or this is restrictive lung disorder. Okay, now this loop is many times asked as a picture question in your examinations. Okay, so watch it carefully. So how it is done? Again, the same method. What is to be done? The person is asked to take a deep inspiration. After taking deep inspiration, the person holds the mouth tube or spirometer, and with forceful efforts, the person is asked to exhale out. Okay, and after completely exhaling the air, the person breathes again from the spirometer. Now remember that two things. One, when the first time person is taking the breath, at that time the person is not breathing from the spirometer. Okay, you will take the air in, then hold the mouthpiece and start blowing the mouthpiece with forceful expiratory efforts till the end of expiration, and this should be at least approximately 6 seconds. At the end of it, he will start breathing again, or he will start inspiring forcefully from the spirometer. Okay, at that time the spirometer mouthpiece is there in the mouth, and from the spirometer itself the person is taking the breath, at that time how the graph will be. When you are seeing here that there is expiration and there is inspiration on x-axis, and that is the flow. Basically this is called a flow volume loop, that's why, and it is in liters per second. Volume is in liters. Okay, so now this is expiratory effort. Person start exhaling, completely exhales. Maximum air flow will be there at the end of FEV1. That will be at the end of first second approximately. That will be the maximum air which will go out. Okay, flow will be maximum during the first second. But as the air empties, the flow will decrease. Volume might go on increasing, but the flow will decrease, and that's why the graph again goes down to the zero level. Okay, I want to say it again. Like let's say I am exhaling, at that time how the graph should come. As soon as I start exhaling, the first bout of air, in the first second, maximum air I will be pushing it out. So the flow of air will be maximum, and that's why it will come like this. Okay. Then at the end of this, what the person does, now the person inhales the air from the spirometer with forceful inspiratory effort, and the loop follows like this. It will come down and again reaches from where it started, and this is the standard flow volume loop. Okay, it should look like this. Normally, just keep this picture in your mind for always. Whenever you are looking at the spirometer result, you should always look for this. If this is there, patient is normal. Now, what is there? It is very smooth. Okay, there is a peak rise. There is no notch. It is like a blunted peak, and it is gradually coming down. Okay, and inspiration also, there are no hesitations in the inspiration, and it is going back from where it started. This creates a loop, and this loop is essential to understand many of the diseases. Just by looking at this loop, you can diagnose the disorders. How they can be diagnosed, that will come to it now. So normally, these are the two basic classifications of the disorder. One is obstructive, another is restrictive. So the obstructive disorder, what will happen is the total lung volume will increase, but FVC, FEV1 will decrease. Okay. And in case of restrictive disorder, here, if you see, the lung volume is decreasing, but the FEV1 is decreasing. Okay. And here, the lung volume is decreased. It is approximately only 3. Okay. And the graph might remain as good as the normal, but the dimensions of the graph will be smaller than the normal. If you see here, it is 5 liters lung capacity, and this is the green one, is the normal uh, flow volume diagram, in which only here what we are looking at is the expiratory part of the flow volume loop. Okay, this again you should be able to understand, because many times what we might ask is, we can ask you to label one of them. This is restrictive or obstructive or normal. Okay, by giving a comparative. Okay, so this is the expiratory graph of flow volume loop, and now one by one. This is normal expiration, and this is a normal graph. Okay, normal person. Now, if a person is having mild obstructive lung disease, now what is happening? Just see it. Here, the expiratory phase, it is very gradual. But here, what is happening? You are getting almost a crescent. Okay, here mild it is. That's why it should be. It can look like crescentic. Okay, and inhalation, inspiration is again normal. This is mild obstructive. But if it is severe obstruction, then what will happen? Person is unable to exhale properly. Okay, that's why the upper portion of the graph will look like this. This is severe obstructive lung disorder. Then variable intrathoracic upper airway obstructions. There can be various causes, and this is variable. Then variable extrathoracic upper airway obstructions. Okay, what is happening here? Exhaling is okay, but again inhaling, the exhaling, the first portion is a little more steep, followed by there is a gradual decrease in the flow. Okay, then fixed intra or extra thoracic upper airway obstruction. The graph might look like this. Then the restrictive pulmonary fibrosis. Now, if you compare this graph and this graph, they look same almost if you just look at them individually. But if you compare with the normal, what is happening? The volume is on the higher side. Sorry, it is on the lower side, and the total capacities are decreased. Okay. Now restriction that is in the kyphosis. Kyphosis is ubadi ana jala mantat ka. That is kyphosis. Okay. And this is the diagnostic criteria. You can see here there is a pre and a post. Okay, what is that pre and the post? It is called as bronchodilator challenge test. Now, this is the way how we should differentiate between the COPD and asthma. Okay. Now, asthma is a disorder where there is terminal bronchos are blocked, but with the bronchodilator, they will open up. So, what is done? The person is asked to perform spirometry, and then a bronchodilator inhalation is given to him or her. And after waiting for some time, we'll again perform the spirometry. And if there is improvement, if you see here in this graph, this is the graph of pre. This is typical obstructive pattern. But after giving the bronchodilator challenge, post challenge, it is coming back to normal. And this is diagnostic of asthma. Okay. But if it doesn't happen like this, then the COPD and asthma graphs will look like same. But with the bronchodilator challenge, the asthma will improve, but COPD won't improve at all. It will remain just like that. And that is how we differentiate between asthma and COPD on spirometry. Okay. So these are the graphs which you should remember always, and these are the graphs which you should keep always handy and keep looking at it whenever necessary, because in final year also, whenever we are coming to asthma or COPD or rest of the obstructive lung disorders, you will come back to this and you have to learn this again. Okay, so better make your concepts ready as of now, and then build your medicine knowledge on these simple physiological concepts. Okay, now maximum voluntary ventilation. What is the maximum voluntary ventilation? In this, what is done? The person is asked to breathe voluntarily with maximum voluntary efforts. That is, person is taking deep breath, giving out, deep breath, giving out. Normal respiratory cycle, it is approximately 10 to 15 breaths per minute. Okay, but in this case, what we'll do? We'll ask the person to take approximately 15 to 20 breaths, and then we'll calculate that against the time, and then we'll calculate the maximum voluntary ventilation in 1 minute. Okay, so patient is breathe fast and deep as possible for 10 to 12 to 15 seconds. Then what we'll do, test for overall, what it does, it tests for the overall lung function, ventilator reserve capacity, and air trapping. Okay, then normal is around 170 liters per minute. That is the maximum capacity of the lung which is possible by the lung to take and like breathe in and breathe out the air. Now here, this is graphical calculation. You have to count the number of waves and then the maximum volume, that average you have to take, multiply it with each volume, you multiply by rate, you will get in that particular time, and you have to multiply with the or convert it into a minute. Okay, that's why it will called as maximum voluntary ventilation or minute respiratory volume. Okay, like that we can calculate them, and these calculations are again essential. I think I should take a separate class on calculations at the end of this respiratory system. Only on calculation will have one different session, that what are different calculation, what are different formulas, and then we'll revise all these things. So as of now, we have come to the end of this lecture, and again remember, please go through this diagrams every now and then. We'll need that. So with this, we'll stop our lecture for today. So keep learning and keep evolving. I think it was okay. And if there are any problems, any queries, you can ask me now, or you can contact me later on my WhatsApp number with you. Okay. So we should stop here today. attendance, please send it on WhatsApp. There are 146 participants which are there online as of now. So thank you very much. Thank you again.